Well, good afternoon, and thanks for joining us for another edition of Silicon Slopes Live. I'm sitting in for Clinton Betts today. My name is Dave Meekum, and I am so happy to have with us Dr. Erin Clark. Dr. Clark is an associate professor and division subdirector of maternal fetal medicine at the University of Utah Health. Good afternoon, Dr. Clark.
Hi, thanks for having me, Dave.
It's really good to have you here, and we're going to talk about something that I think is super fascinating. And I just know that there are a lot of people that have these questions, and of course, it's no surprise since we're in Utah. Most of us know that we have one of the higher birth rates in the country. I think one of the numbers that we got from you guys is 47,000 births a year. That's a lot of people that are born here every year. And so that at any given time, we have a lot of women who are pregnant. And with everything going on surrounding COVID-19, and it's a challenge anyway, just to have, to be pregnant. There's all those variables and all those questions and always a little bit of anxiety anyway. And then when you kind of throw COVID-19 into the mix, that just kind of doubles down on all of it. So we thought we'd have you come on today and maybe talk and address some of these issues regarding pregnancy and COVID-19. My first question that I would like to ask you is, COVID-19, are pregnant women more likely to acquire the virus? And if they do, is it going to make them more ill than anybody else?
Yeah, it's a great question. So our knowledge of COVID-19 is obviously evolving, and we're getting more information over time. As far as we know right now, pregnant women are as likely to get it as anybody else. It seems like there's a large proportion of the population, and that includes pregnant women who are getting it and not having any symptoms. If people do get it, it seems like it's most likely to be mild or moderate in nature. We certainly know that other viruses in pregnancy can affect women more severely, and influenza is probably the classic one that we talk about. So a woman who gets influenza in pregnancy is more likely to get ill or critically ill when they're pregnant. When it comes to COVID-19, though, it seems like it is different than influenza in terms of women who get it tend not to get more ill than anyone else in the general population, and their symptoms seem to be about the same when they do get it. So in contrast to influenza and some other viruses, it seems like COVID-19 is not more likely to make pregnant women ill, and they're not more likely to get it than anybody else, which is good news for our pregnant folks who, as you said, have enough to be anxious about already without the pandemic.
Yeah, it's really a challenge, or it can be, just to be in that condition and then just have something else to worry about. I just can't imagine how difficult that might be. So another question I'd like to ask is the symptoms of COVID-19 in pregnancy. Are the symptoms different from the general population? Or if a woman who is pregnant gets COVID-19, is it going to be better, worse, different? Is there anything to talk about there?
As far as we know, when they have symptoms, they present the same way. And again, we're getting more information over time, but it seems like the things that the general population reports are the same symptoms that pregnant women who get it are reporting. So the most common things are fever and a dry cough. People will also report that they have a lack of appetite and are very fatigued. So that list of symptoms seems to be about the same in pregnancy. Now, pregnancy can make people feel a little different at baseline. They might be a little more likely, for instance, to have a little feeling of shortness of breath when they're carrying a baby. So it can be a little bit more difficult to differentiate. Is this normal pregnancy symptoms, or is this something new and different? And we try our best to figure that out when we're talking to women. It's usually the new, the different that gets our attention. But in terms of symptoms, it doesn't seem like pregnant women have different symptoms than anyone else. We are finding out from areas that have higher prevalence, like the hospitals in New York City, that a lot of women who carry the virus are not having symptoms. So over 80% of people who tested positive for the virus in a study of New York hospitals and labor and delivery wards, over 80% of women who tested positive in pregnancy did not have any symptoms. So it seems like you can certainly be a carrier and have no symptoms at all. If you do have symptoms, they seem to be the same as the general population. And most people, if they have symptoms, they're mild or moderate in nature.
Is there any risk or higher risk for pregnancy complications or miscarriage or birth defects for women who are unfortunate enough to contract the virus while they're pregnant?
It's such an important question, and obviously something that our pregnant women and their families are very worried about. So far, data suggests that we aren't seeing higher rates of miscarriage, that we're not seeing higher rates of birth defects, and we're not seeing higher rates of other pregnancy complications like preterm birth in women who have COVID. That seems to be mirroring the data that we have for other coronaviruses. And so we feel like it's unlikely that we're going to see those effects even as we get more data. We do acknowledge that any woman who has critical illness in pregnancy, if they're in the ICU, if they're experiencing severe symptoms, the severe illness itself can be associated with pregnancy complications. So whether you're in the ICU because you have a severe case of the flu or because you have COVID-19 or you have some other illness, those women we know have a higher rate of delivering early for a variety of reasons and can be more likely to have babies who are low birth weight. But as long as you're not critically ill in the ICU, we don't think that there's an increased risk of other pregnancy complications. Now, we still acknowledge that we don't know everything about this virus. We are learning more every day. And so some expert organizations have said, if you contract this virus in the first trimester, you should be especially careful to get that normal mid-pregnancy ultrasound that looks at all of the baby's anatomy to make sure everything's well developed. That's a standard part of pregnancy care, but might be even more important if you've had the virus. And other people who said, if you have this virus in the second or third trimesters of pregnancy, maybe it's more important that we take one look at the baby's growth, one additional look than we normally would, just to make sure things are going okay. And those recommendations are not based on hard and fast data, but are just based on our acknowledgement that, again, our knowledge is evolving, and maybe we should be a little bit conservative and follow these pregnancies just a little closer.
That's interesting. So, but at least I guess the bottom line is so far so good as far as that goes. So if you are in this position, if you're a woman who's pregnant and contract the virus, how does the care differ? Are there additional ultrasounds that are required, additional monitoring, anything like that? Or does it change the type of delivery that might be necessary, or timing, anything like that?
I mean, I think if you have the virus, in the first trimester, like we said, maybe one additional ultrasound to look at the baby's growth, making sure you get that ultrasound to look at the baby's anatomy. But otherwise, once you're a recovered woman with COVID-19 in pregnancy, your risks are about the same as anyone else. And your labor and delivery plan, when you come in for delivery, whether you have a vaginal birth or a C-section, whether you need an induction or can wait for labor, those should all be according to the usual obstetric care. So if you get it and you've recovered, we might look at your baby a little more, but otherwise your care can really be the same. I think regardless of whether you have the virus, prenatal care is looking and feeling a little different for folks these days. Because we are trying to keep people from getting the virus. We said pregnant women are as likely to do well with the virus as anybody else. We still don't want them to get it, and we're all taking precautions to try not to get the virus. And for us, that means that in pregnancy, we're trying to reduce the number of exposures by keeping people out of clinic and out of the hospital whenever we can. So for women in general, that means that we're doing prenatal care in new and different ways and trying to do at least some proportion of the visits by telemedicine. Lots of pregnancy care is counseling and discussion and reassurance. And so unless you need a physical exam, an ultrasound, or labs, some of these visits can be done by telemedicine very safely. And it's actually been a program that's been very effective for us at the University of Utah.
That's interesting. And I'm sure that kind of leads into another question. Then we talk about trying to prevent the virus from getting into the delivery room or the hospital. But if a woman has it, can she pass it on to her baby either before the baby's born or after? How do you, because obviously the baby has to have access to mom. How does that work? What are you guys doing there?
So the first question is whether someone can pass it to their baby while they're still pregnant. That is called vertical transmission, when you pass it through the placenta or through the process of childbirth. And while there's been a couple of case reports that have asked the question, did this happen? Did this baby get it in utero? That has not been shown for coronavirus yet. So that's in alignment with other respiratory viruses that seem like they don't pass to the baby during pregnancy. So far, we don't have data to suggest that. but the baby is at risk for acquiring the virus as soon as the baby's born. And so there are some precautions that need to be taken when a woman has a known COVID case, when she's known to be affected and she's just given birth. I think moms, their biggest concern in that situation is that their baby's going to be taken away from them in order to try and prevent the baby getting the infection. And we're just careful to reassure mothers and to tell them that this is not a mandatory separation. This is a situation where we talk to you about the pros and cons of staying together versus separating and decide on what's best for you and your family. But it does mean that we do some, unique things to try and prevent the baby getting an infection. Meaning, even if you have the virus and you decide to keep your baby with you, we're especially careful to make sure that you have excellent hand washing, that you wear a face mask when you're breastfeeding. If you choose to provide breast milk for your baby, that all that equipment is washed very well, and that someone who's low risk for COVID would give that breast milk to your baby. There's lots of different ways that this care can be done when a mom is infected, and lots of different ways we can prevent the baby from getting infected. And so we have a conversation with the parents and our care team and come up with a solution that meets their needs the best.
Wow, it's really interesting. If a woman's pregnant and works outside the home, is that safe?
Because pregnant women don't seem to be getting more severely ill with COVID-19, there isn't a medical reason that they can't work outside the home. They need to be just as careful as the rest of us to try and avoid getting the virus. Careful hand washing and masks are part of that, as well as physical distancing. So we all should be doing those things. When we talk about someone being a healthcare worker, it's a little bit different. So if you work in a healthcare setting where you might be more likely to be exposed to COVID, we are trying to keep people out of known COVID positive rooms or out of rooms where people might have COVID, just to be as an extra precaution. And because our healthcare system currently has the capacity to handle the number of patients, we can take pregnant women out of those higher risk exposure situations. And we're talking to pregnant women about the fact that while there's no reason that you can't be working, some women are choosing to come off of work for the last couple of weeks of pregnancy so that they avoid getting a late infection in pregnancy, which might have implications for that decision to separate mom and baby. So some women are saying, you know what, I'm going to work through my whole pregnancy, but especially since I'm a healthcare worker, I'm going to come off the last couple of weeks just to self-quarantine a little bit more to prevent that chance of getting an infection right before childbirth.
Yeah, there are certainly some professions that kind of throw you right into the middle of it, aren't there?
There sure are.
If you just had your baby, people want to come in the hospital and see you. Can you have visitors?
Right now, most hospitals are limiting the number of visitors. So every hospital and hospital system is tackling this differently, but most people are saying you can have one special person come with you during childbirth and during the postpartum period. So those days of having, those big happy family groups of 5, 6, 7 people in the room for a delivery are over for now. We are still encouraging those family members to join using FaceTime and other video chat apps so that they can still be part of the process. But we are really trying to limit exposure to our patients and to our care providers by having just one person there.
What about if they have a more professional role, like somebody like a breastfeeding coach or a doula, somebody like that? Is it any different for them?
If they're part of our hospital staff, they can still see the patient. So if our lactation specialists are part of our critical healthcare team, so they're still seeing patients who need them. If it's someone coming in from the outside, like a doula, a labor coach, right now, those folks are not able to come into the hospital unless they are chosen as that one special person. That doesn't mean they can't be involved in the care, though. And again, we are recommending that they try and join by video so they can still help with that labor coaching. It's not a perfect substitute by any means, but it's still very helpful to have them as part of the process.
Well, that's good to hear. If a woman is approaching labor and kind of anticipating this, is she going to be tested? I assume she's going to be tested for COVID-19, even if she doesn't show symptoms?
So Centers for Disease Control says that it's an option to test everyone when they come into the hospital. A lot of hospitals have converted to that because it allows us to know if a woman is infected when she comes in, because it obviously has implications for her and her baby and her family's health. So at University of Utah and at most other regional medical centers are doing something called universal screening. So if you're coming in for a scheduled induction of labor or a scheduled C-section, your doctor or midwife is putting in an order for you to go through, usually drive-through testing a day or two before your admission, so that we have a test result when you come in. Lots of childbirth is not scheduled. And so, when you come to labor and delivery in labor, we are often sending testing when you come in if you have not had that testing beforehand. And our testing now can get us a result in as little as an hour.
Does that include the partner or dad or, who was going to come in and be a part of this?
Not right now. So, we are testing our patients, the birthing mother. The partner is not routinely being tested. If a partner has symptoms, they're asked not to come to the hospital, but could then order a test through their own healthcare provider. And everybody in the hospital is being asked to wear masks as a way to try and reduce risk of exposure. The exception is for a laboring woman who is known to have a negative test. It's sometimes hard to wear a mask when you're in the midst of labor and pushing out a baby. And in those cases, often women take their masks off, which is supported.
Okay. So it might not be a bad idea, though, if you're going to be part of this, to get yourself tested voluntarily anyway, just to be safe, right?
Yeah, I think, if you are an asymptomatic partner, you may not have an indication for testing. But I think the woman coming into the hospital, there are mechanisms in place to make sure we have a test result for her.
Okay. If a woman has tested positive, what's the prognosis? What's the outlook for her and her baby?
Well, most pregnant women either have no symptoms or have mild symptoms. Certainly there are situations where people have gotten more severely ill in pregnancy, but those cases are much less common. So we watch a woman for symptoms and mostly try and take those measures that we talked about to try and prevent her spreading it to her baby or to other family members. But there's reason for optimism. Most people do very well.
What about, how does this impact breastfeeding?
So we have not yet found COVID-19 virus in the breast milk itself, which is good. And we also know that mom passes important antibodies to her baby through the process of giving breast milk, whether it's breastfeeding directly or pumping breast milk for the baby. So we very much encourage breastfeeding in this situation and remain really strong breastfeeding advocates. Right now, other than droplets, which, if you cough and you have COVID and you could cough around your baby and that could pass it, but we don't think it's passed through the breast milk itself. So breastfeeding is very much still supported.
Yeah, it's super important. I think I always have. It was a great help for my kids. So the hospital stay, woman goes to the hospital, she's got COVID-19. Is it going to be a longer stay, or could she expect a normal time in the hospital?
Well, if she actually tests positive, it totally depends on whether she has symptoms or not. Most people who don't have symptoms or who have mild disease would go home in the same time frame that they normally would. For the people who are negative, it is impacting their hospital length of stay because we're trying to get people out of the hospital environment as soon as it's safe to do so. So there's been a big push nationally, even before COVID-19, for shorter hospital stays because we know hospitals aren't the lowest risk environment and people would rather be home. So we are generally getting folks who have a vaginal delivery home within about 24 to 48 hours and really shooting for the earlier end of that window. And for a C-section, 2 to 3 days. COVID-19 has just forced us to evolve as a hospital, a healthcare system, and as a national healthcare system to try and get people home more quickly when they're ready to. We're also careful to emphasize if people have a medical need to stay or a preference to stay, we work with those women and their families to meet their needs.
Interesting. Okay. So another question, women preparing to give birth, a lot of times they've been taking classes in person, trying to prepare for that and the coaching aspect of it. Are there virtual classes available right now? Are those classes in person available? I'm guessing maybe not. Are there virtual classes available if there aren't?
Yeah, so much of our care has evolved to a virtual format, which is not exactly the same, but still provides really good content. So all of University of Utah's birthing classes have evolved to a virtual format. So people join and they learn together virtually. Even tours of labor and delivery can be done in a virtual format. It's not a perfect substitute, but it still gets people the information that they need. Much like prenatal care visits, we're just learning how to provide the same high quality care in a new and novel way in the midst of the pandemic.
Interesting. So what about kind of staying on that virtual theme, postpartum care? Is that going to be in person, or is that going to be virtual as well?
We really try and individualize for women. So some women have a need for a physical exam, often they do, just to make sure they're healing well and things are going well. But lots of postpartum care, just like prenatal care, is education and reassurance. And so sometimes we can get away with virtual visits. So we talk to a woman, see what's most appropriate for her specific situation, and then make a decision about face-to-face or virtual. For any woman who really wants to be seen face-to-face, we will always see them face-to-face if they desire it, even if it's not necessarily medically indicated.
That's always the best way, I think, for healthcare is personalized, right?
Flexible and personalized is very important.
Well, Dr. Erin Clark, it's been great to sit down and chat with you a little bit about this. I think it's been a fascinating conversation. I hope it's helped a lot of folks. I'm sure it has. And hopefully we can get you back again at some point and talk more about this. Would that be okay?
That would be great. I think we are learning more every day, so I expect new knowledge to inform our decision making going forward. I suspect we'll have new things to share.
That sounds fantastic. Well, thanks again for joining us today, and we'll look forward to seeing you next time.
Yeah, thanks very much for having me.